So this is going to be part two of our endocrine and hematologic emergencies. We'll be talking about disorders involving the blood and clotting. So hematology is the study of all blood-related diseases. Four different disorders that we might see in the pre-hospital setting to cause us some problems would be sickle cell disease, hemophilia type A, which is usually found in males, thrombophilia, and anemia. So let's talk about blood. Blood's made up of four components. The big words for them are erythrocytes, which are red blood cells, or leukocytes, which are white blood cells, platelets, and the plasma that everything is floating around in. Red blood cells contain hemoglobin. Each one of them carries oxygen, or which carry oxygen to the tissue, and each hemoglobin carries 4 oxygen molecules. Whenever we're using a pulse oximeter, it's actually looking at what percentage of those available spaces on hemoglobin are occupied by something. Not necessarily oxygen, but by something. White blood cells collect dead cells and provide for their direct disposal, help to respond to infections. And platelets are essential, obviously, for us forming clots. That's one of the reasons why we give aspirin in cardiac patients, because it makes those platelets a little more slippery so they don't stick together and clots don't get any worse. And we just said that the fluid portion is the plasma. Sickle cell disease. We'll talk about the different conditions. It is an inherited disorder. It affects red blood cells specifically. It's found predominantly in people of African, Caribbean, South American descent. People with sickle cell, they have sickle-shaped or misshapen red blood cells that can lead to oxygen having a problem binding with the hemoglobin inside, and also with unintentional clot formation, as they don't slide through the valves in our vessels as a normal shaped cell would. Those clots can result in blockages known as vaso-occlusive crisis. It's very painful for our patient. But if those sickle cell or those sickle-shaped red blood cells get bound in a particular vessel, then that obviously occludes that vessel, and anything past that vessel that it would normally feed oxygen and nutrients to is cut off from those oxygen and nutrients. So sickle cells have actually a short lifespan, which results in more waste products, as in we have more dead blood cells for our body to get rid of. We know that our bodies, the blood cells in our body are regenerated, and old ones die on a continual basis. But this happens more with those sickle-shaped cells. The complications that can go along with sickle cell disease are going to be anemia, which is a low red blood cell count for those active blood cells that carry oxygen normally. Gallstones, jaundice, which is the yellowing of the skin in relation to liver failure, and might even have some dysfunction in our spleen. If we have a vascular occlusion and the oxygen is cut off on the distal side of that, we know that that's called ischemia with a lack of oxygen. And we could literally, it could result in anything from stroke to the pain crisis. These patients have an excessive amount of pain, even to retinal hemorrhages and increased risk of infection. We can also get acute and chronic organ failure, or at a minimum dysfunction. So you can see in the picture there the shape of those sickle cells and how they're not quite as bright red as the other ones. They don't have that that amount of hemoglobin inside where they're able to transport. We also have another condition might be blood related that we see, and would be hemophilia. We've all heard of it, but only about 20,000 Americans actually have true hemophilia. And as I mentioned earlier, hemophilia A affects mostly males. It's basically the body's inability to clot. And so if a patient has an injury, it could be anything from just a small cut on a finger to some type of major trauma, that decreased ability to clot can be life-threatening because your body is not able to respond to keep that blood and those red blood cells in the vascular space where it can, or the vessels, I should say, where it can deliver oxygen and nutrients the way it's supposed to. Patients can be prescribed medications. They get clotting factor that can be injected or taken orally. You can give medications that to prevent the breakdown of blood clots. Problems that can be associated with hemophilia would be if patients have long-term joint problems that require a joint replacement, then that obviously, so any surgery is a complication, not to mention the fact that they do have an increased risk of joint problems that require joint replacement. Also, a simple bump on the head that may be nothing to us, but a bruise could cause bleeding in the brain, or if they, due to that clotting factor treatment, if not dialed in appropriately, they could actually throw a clot somewhere and it become life-threatening. So thrombophilia is kind of the opposite. Whereas hemophilia is the body's inability to clot, thrombophilia is the body basically clotting excessively. Concentration of particular elements in the blood creates clogging or blockage issues in vessels. And just like with a sickle cell, when you get a vessel that's occluded, obviously any vessel that's occluded, the tissues on the distal end of it don't receive what they need, and it can cause lots of problems. Thrombophilia is just a general term for any condition that results in blood clotting more easily than normal, and clots can develop literally spontaneously. It could be anything. This could be caused by anything from an inherited genetic disorder to medications they take, or patients with cancer. So any of the origins of a clotting issue, it's still all kind of housed under the umbrella of thrombophilia. DVT, or deep vein thrombosis, is a common medical problem in patients who have just had surgery and they just sit around. That's why you see a lot of people that come out of surgery, they're wearing the compression stockings. They'll take blood thinning medications for a period of time, either before or after, and sometimes with mechanical devices. But it's basically in a deep vein, we get a clot, and it can be very, very painful. It can cut off that circulation that we've mentioned numerous times already. And so joint replacement surgery is obviously a big risk factor because of the vessels involved and remaining sedentary for long periods of time. So anyone with any kind of clotting factor issue that remains sedentary for a long period of time can obviously develop clots, as the blood is not being forcefully circulated through those deep vessels. They might get some kind of anticoagulation therapy, some kind of clot buster as a type of treatment, but medications are typically administered for at least 3 months regularly after someone is diagnosed with a DVT or deep vein thrombosis. The clot from a DVT, the problem is it can travel from a lower extremity to the lung, causing pulmonary embolus, or even depending on how things work out, it could go to the heart or the brain. You'll also see people mention that they put in a quote unquote, the doctor put in a screen or a filter. They will put in at times mesh screens and filters in vessels to filter out clots, so those are unable to travel and cause other problems. And then we come to anemia. And anemia is basically just an abnormally low number of red blood cells. And it can be for a lot of different reasons. It could be if you had some kind of chronic bleeding issue, GI bleeds and that type of thing, where you're constantly losing red blood cells or losing blood at a greater rate than they're produced by the body through stool or whatnot. You might have a deficiency in certain vitamins and minerals, iron, for instance, or there may be some kind of underlying disease process. But the blood's unable to deliver adequate amount of oxygen and nutrients to the tissues because it doesn't have enough red blood cells. We don't necessarily, the problem with this in our assessment is that pulse ox may indicate an adequate saturation, because like I said earlier, pulse ox literally looks at the percentage of available slots in a hemoglobin, and it says, okay, well, you have this much hemoglobin, this many slots are occupied, 95% of them are occupied, well, then you have a 95% saturation. And we look at our pulse ox and we go, great, 95 is good, 95 is where we want to be. The problem is the pulse ox doesn't understand that there aren't as many red blood cells there as there should be, because of a condition called anemia. So that that can be a big throw off for us. So you have to always keep that in mind. Use your pulse ox and all your medical tools as just that, tools, but always treat your patient. Never treat your machines. So we know how to do a scene size up by now. We've covered it only about 7,000 times, but we got scene safety, PPE, number of patients. Is this MOI versus NOI, or nature of illness? I mean, a mechanism of injury versus nature of illness. We're going to always be alert for possible trauma, whatnot, and consider ALS support. Most sickle cell patients that we might respond to will have had a crisis before, and they'll be able to tell you almost immediately that they're in crisis. If there is any trauma, obviously we do C-spine. We get that general impression, looking for the things that we want to know. Are they making eye contact? What's their skin look like? Basically just determining how sick does this patient look. And then we're going to start doing our airway and breathing. We want to make sure that our airway is open, it's maintainable. And if they have, and we want to rate rhythm and quality of breathing. If any of that is not adequate, if they have, they're not breathing properly, or they have an altered mental status, we're going to go ahead and put them on some high flow O2, try to get that bumped up. Sickle cell crisis patients may have increased respirations, potentially signs of pneumonia. So we would manage that with by opening the airway and possibly using an airway adjunct, whether it be an OPA or an MPA. And then we might, along with providing oxygen, we might also assist ventilations as well. Circulation, sickle cell patient is going to have an increased heart rate. Obviously, they're going to be in pain. Anyone in pain has an increased heart rate. But if you have a suspected hemophilia patient, make sure that you do more than one hemorrhage scan. Look for bruising on the body, because that could be it could be internal bleeding. And anytime we have signs and symptoms of shock with no obvious reason for that, we assume that the bleeding is internal, and that's for every patient, but even more so for patient who suffers with hemophilia. So make sure that we always, and also make sure we keep an eye out, just like for everyone, signs of hypoxia, and determine if this is how life-threatening is our situation right now, and make our transport decision. Investigating a chief complaint, we already know how to do that. Physical signs of sickle cell crisis, you might have swelling in fingers and toes, or a priapism, which is an erection, or jaundice, and these things are related to blood being trapped in a particular cavity or area, and the vessel being blocked, and so that blood cannot escape back into normal circulation. And so we see that's where we get our swelling from. Ask about things like, is this hurt? I mean, our OPQRST, is this thing going on right here? Does it rotate out anywhere? Do you feel it anywhere else? Do you have any visual disturbances? Have you had any cramping, nausea and vomiting, chest pain, shortness of breath? We don't want to overlook other potential problems by assuming that we know what the issue is. Obtain a sample history, and when they tell you they have sickle cell disease, have you had a crisis before? How long has it been? How did it resolve? Have you been under any recent stress, or have you been recently ill? Anything that may have exacerbated the issue. And then our secondary assessment, we know how to focus on major joints, look for that blood pooling, look for swelling, obtain complete vital signs, look for those signs of sickle cell crisis. Make sure we use a pulse ox if available, but also remember that pulse oxes can be unreliable. And then we reassess those vital signs frequently. If we consider our patient to be critical, we would reassess our vital signs every 5 minutes anyway. And we evaluate the interventions that we've used. Now, bleeding disorders are very hard to diagnose unless someone looks at you and goes, hey, I cut my finger and I have hemophilia, or hey, I'm in crisis with a history of sickle cell disease, it may be hard to determine what the problem is, and they're even harder to treat. So, but we don't have those issues. There's not a lot we can do on the EMT side of things other than maintain airways, support ventilation, and support circulation with the tools we have available, and transport them as quickly as possible. So mainly supportive and reacting to symptoms for our treatment, high flow O2, positions of comfort, and rapid transport. And that's it for this segment. We'll post some review questions in a while.